All right. I see a lot of people in the chat sharing where you're from. Thank you so much. And thank you so much for joining. We can go ahead and change for next slide. So here's today's presentation in Spanish. Uh, Please go ahead and go to the interpretation tab. Dr. Colon, please change the slide now. Yeah, please go to the interpretation tab on your Zoom panel and click the Spanish. And you can also mute the English speaker's voice by clicking mute original audio. Uh, Change slide. Now we're going to be reviewing a few housekeeping items. Today's event is being recorded and will be made available publicly through our website and other media channels. For today's webinar, all participants will be muted. If you would like to speak or ask a question live, you may raise your hand and you will be given access to unmute your microphone. Please make sure your computer speakers are turned on and up to hear today's presentation. If you're having technical issues, please send a message to the Hispanic Latino Behavioral Health COE on the chat box. If you have questions for our presenter, we ask that you use the chat. Simply type your question and hit send. We can address the questions to the presenter at the appropriate time or during today's presentation. We can also do them at the conclusion. We will be sharing a copy of today's presentation in a PDF format through the chat box. We will also make a copy of today's presentation available to be downloaded through our website, and you can find it under the name of today's event. Please complete the evaluation. The evaluation will help us know more about your opinion and thoughts about this presentation and what other topics and trainings would you like to see offered. A link to the evaluation will be shared through the chat, and you can also scan the QR code at the end of the presentation to complete it. You will receive a certificate of attendance by email approximately 1 week from today. Please remember to check your junk folder. The mission of the Hispanic Latino Behavioral Health Center of Excellence is to advance and support the sustainability of behavioral health by promoting community-driven, culturally grounded, and person-centered prevention, treatment, multiple pathways of recovery, and recovery support for Hispanic and Latino community. And we strive to accomplish this mission through the development and dissemination of culturally informed, evidence-based behavioral health information, providing training and technical assistance, and supporting the growth and expansion of the behavioral health workforce that serve the Latino communities. At this time, I'd like to turn it over to Dr. Colon, who will introduce himself and begin the presentation. We hope you enjoy today's webinar. Welcome, Dr. Colon.
Thank you for the invitation. So I'm Hector, Dr. Colon Rivera. I'm in Philadelphia. I'm the medical director for a nonprofit called Asociación Puertorriqueños en Marcha. So about 90% of our patients are from Hispanic Latino communities, and also work with University of Pittsburgh doing telehealth, telemedicine, running an IOP program in rural Pennsylvania. So welcome. I see a lot of states representations here. I mean, Puerto Rico's in the house as well. So welcome. This topic is a kind of broad but also pretty dense topic, especially because for those that are parents and have also lost someone in their family. So probably all of us have gone through some stage of grief or bereavements in the past. So let's start. So we have three main objectives for today. We're gonna analyze how grief affect us, especially our mental health, and those that have disorders are, of course, more at risk of having severe symptoms. We're going to talk a lot about how this affects the Hispanic and Latino communities. We're going to identify how cultural and systemic challenges for Hispanic and Latino individuals face, and how they manage grief challenges, and also highlight the opportunities for cultural responsive support for healing, and also the resiliency in this community. So General numbers in terms of mental health in the Latino community, I mean, about 20%, so one in five adults have a mental health condition in the past, between the past years, last 12 months. About 5% have a serious mental illnesses. I mean, that's a perspective. By serious could be substance use, also could be usually they refer to bipolar or psychosis. Um, Only about 15% received treatment in the past year, and I think that's probably decreasing now with the some of the cuts on insurances and support on the government, but also for Hispanic community, there's not a lot of support in terms of data. I mean, a lot of clinics are closing or merging, so the area they're covering is a lot less. Yes, telehealth medicine helps, and hopefully we can maintain that expansion in telehealth, especially in rural areas where most Latinos are moving now. I hear a lot of ideas out there. It's, at least in Pennsylvania, a lot of Latinos, like Hispanic, are moving to rural areas. In terms of suicide thoughts, no attempts, no gestures, so only thoughts, thinking about it. It's about 4.6%, so almost 5% has serious thoughts of suicide, and about 1 to 2% has made the plans. I think these rates have decreased in the last years, but again, we having more the overdoses without knowing is it intentional versus non-intentional. From 2021 to 2023, Hispanic students are feeling hopeless and sad, but we have seen a decrease. Even, I mean, it's a probably a minor decrease of 10%. You compare 46% versus 42 in the last year, and suicidal ideation planning are also decline. In terms of grief, which is a topic of today, so in terms of grief, I'm going to use the PGD as a that stand for a prolonged grief disorders. So we see it's about 10% of individuals, and includes symptoms like intense yearning, emotional numbness, and some suicidal risk. I mean, we think about going to the person that we lost, but with having some passive thoughts of dying. In terms of the diagnosis itself, I mean, is recognized by the DSM-5 TR, and the ICD-11, ICD-10 also have the diagnosis for it, and you can bill for that. Comorbidities, of course, depression, anxiety are the most common, but there are also some somatic issues, which are pretty common in Latino Hispanic communities. So grief is our topic, and bereavement is, those that speak Spanish, it's kind of hard to define this one. I mean, in terms of translating it or interpreting it in a different language. Luto, I think, is one of the definitions out there, or duelo, right? For some Hispanic communities. However, between grief and bereavement, there's not a lot of differences. I mean, it's just referred to the death of a loved one, but it's just a broad term for grief. When we talk about stages of grief, I mean, some of the psychologists have used bereavement as a stage of grief. So we will talk about that a little bit later. So what it is, I mean, it's just encompass the entire experience of family members and friends with the anticipation, the death, and subsequent adjustment to living following the death of a loved one, right? So if and of course, most of us, when we lost someone, there is some changes of lifestyle, structure in the family, especially for those that are in charge or have our living in a way that they are the structure of the family, like grandma, grandpa, usually in Hispanic communities. So it's a big loss, and also changed the life of most of the family members. So grief is a natural response to loss, It doesn't have to be a human. Losses are also materialistic or animals, right? When we lose animals, not like humans are not animals, but when we lose our dog, right? This is pretty grief moment for the family as they're part of the family. Most often following the death, right, of a loved one, but also I have a patient today, for example, that the niece went to college today, right? It's the first day of school, so it's a big loss for her. She's raised the niece today, so you're starting school. Those are your parents. The kids start school, they go to K, they go to pre-K. So that's a big a transition of stages that there is some grief inside of you because it's a loss. You're losing time with your kids, and in this patient I saw this morning, well, she's losing in her words, she's losing her niece. With she went to college today. It could be multidimensional, involving the physical, emotional behaviors, social and spiritual changes. It's a change, for example, to my patient, and the entire life was around her niece. So now she needs to think about what is there for me. So that's a great example of how grief affect our whole life. While grief is universal, is the intensity, the duration, and expression vary a lot among individuals and family members. Common experiences include distress, anxiety, the sadness, and the preoccupation with the loss. There's a lot of rumination, the what ifs come up. Most people gradually adapt to the bereavement. We have a long-term health consequences. However, there's some complicated that are not just acute grief that can affect our health, our physical, our spiritual, and mental health. So acute grief, so that's the first shock, the numbness and denial. Even when you have a family member, right, that is sick and you have seen getting sicker, a good example is cancer, for example, and you're taking care of that family member, and there's a deadline, there's an expiration date, or especially when they're in hospice and they're giving you, I don't know, 3 months. So but it's not like when you get that acute grief that the sadness, the emptiness kicks in. There's a lot of a sense of loss, anger, regret. The guilt goes up. Of course, the fear, the loneliness, and depression, depending how connected you were with that person. And even I have patients that, I don't know, a second, third uncle dies, and then they start thinking about, I didn't even know this guy, and I feel sad. It's a loss for the family. So that multidimensional situation is there, right? So it doesn't even require you to be close to this person to feel that acute grief. There's something called integrated grief, which is pretty interesting. It's a later phase when grief becomes part of your ongoing life. This happens a lot. I see a lot of on mothers that they lose their kid to violence, or they die in an accident, and they still feel that pain, but it's a little bit with time. They start living with that pain, but it gets softer. They have the capacity for joy, the purpose return, even though the kid is not there. They still feel the kid around, and they can live with that, feeling joy when the birthdays come up, or feeling joy when they see the grandkids. And that's an integrated grief. So the grief is there, but they're integrating them, that feeling to their life and their purpose. It's a continual connection to the deceased, and through memories and traditions. Again, when you celebrate memories, when you spend time with the person that you lost in terms of their kids and things like that. So that's the integrated grief. It's just a renewed engagement in daily activities and relationships that surrounded that person that you lost. And the different cultures. Those of you guys are from Mexico and other countries. They celebrate this type of feeling, honoring the deceased. So during the Dia de los Muertos, if you've seen the movie Coco, I believe, is a good message on that, and how they celebrate that, how connected they feel with the members they have lost. So storytelling, and they have a family gathering celebrating that. There's some theories around bereavement, and those of you guys that study psychology or behavioral health probably are familiar with this. There's a lot of around the breaking attachment bonds, and the traditional view is like it's a healthy adjustment, letting go of the emotional ties to that person that passed away or the animal that passed away. Uh, they focus on the moving on and forming new attachments. Uh, but there are some risks to that theory. Is you may overlook the cultural and personal needs to keep the connection alive. Right, when you lost someone, there's some you lose not only seeing that person, but also the connection you have, the way that person made you feel, and so on. The other is not a traditional way, which is a contemporary, more progressive, and they add the cultural view of it, which is a healthy adjustment as well, but allows the ongoing symbolic connection to that person, integrating the loss in one's life narrative. So you keep mentioning it. I mean, some people try to forget the loss, but in this theory, you keep mentioning, like my son, if he was alive as a part of you. Okay, I'm going to visit my son, for example. We Hispanics do that a lot. I mean, they take flowers, they take gifts. Some of my patients even make cakes and take it to the cemetery, and they celebrate the life of that son or daughter they lost. In the Hispanic culture, I mean, they have some rituals. They go back to church. Uh, they celebrate their anniversaries and storytelling, and there is that bond that's sustained while adapting to the life without that person. So that's the cultural view when we talk about bonding, the theories of bereavement. Attachment theories, I mean, they're pretty dense. I found them pretty dense, but pretty important. Probably you guys are familiar with some of them and the stages of attachment. I mean, this is back in the days, probably when Schaefer and Emerson were around, and they study a lot of attachment, relationship on infants, uh, and they followed the infant for like 18 months, and they were able to create some levels of stages from birth to when the patient is 3 months, and then 3 months and above until the kid is 18 months. So there's a pre-attachment, the attachment between 6 weeks of age to 7 months, and then there is the last one, which is 9 months and above. So this is what help us to differentiate what's the secure attachment versus avoidant dismissive attachment. If you have babies, you have kids, you have seen this, how they do try to be independent, but at the same time they want to be with you. So you see the stages, how close they are, and that fear for the people that they do not know. I mean, that's good. That's a good development. They need to fear what they don't know, right? There's some issues when the kid goes to anyone in the family or any a person that they do not know. So secure attachment is part of that independency that the baby is creating, but also creating some kind of fear around the unknown. So secure attachment is defined by the loss of painful but tends to evolve towards integrated grief. So integrated grief with what we discussed before. So it's integrating that part. So it's part of the development. It support the system that we are trying to build. Also, there is people define it by anxious or preoccupied attachment. Again, this is secure attachment. Again, we need to fear what we don't know. There is a risk of prolonged grief disorder due to dependency on the disease. So this is not just about babies, but babies an example. So when you try to adapt and secure attachment with that person that you lost, but attachment still strong, and when you are challenged by people, hey, you should. A good example is when you still have the clothing or the belongings of that person, or no one can go to the room. Which, sure, I mean, people can say, well, I'm keeping the room because it's still part of my life. But at the same time, you're building a prolonged grief disorder where the dependency of you having that room for your son, which is not coming, it could get dangerous, and attachment can be risky at that point, because if someone take their stuff, you will feel mad, you will feel angry, right? So there's a lot of triggers during that process that probably can convert to a disorder or even a post-traumatic stress disorder. There's the avoidant and dismissive attachment, which is when people try to suppress emotions, the tendency to avoid reminders or losses. So I don't want to talk about it. Don't tell me about it. I don't know what happened with him. Don't tell me it was an accident. I keep saying son because it's I treat a lot of women, but it could be it could be a daughter, it could be a father, it could be anyway, anything, any family member, and any of the triggers might trigger intense emotional dysregulations, right? Some of my patients, for example, they try to kind of hide emotions, and they try to isolate. They stop going to family gatherings. They don't want to talk anything that's related to the person that they lost. So this create the avoidant, dismissive attachment, create a lot of vulnerabilities, and it could be a complicated and traumatic grief. So the more time you spend trying to avoid that emotion, avoid the reality, it could be painful, it could convert to a disorder. So how do we reconstruct what's going on? I mean, this is just the process of organizing life events, especially when you have a big loss in how you narrate that loss, right? Again, I think integrating the grief as part of your life is the way to go. That's at least when you are in therapy, I think it should be that way. But some people are not ready, right? It's less about getting over. So we're not talking about that, moving on, getting over. It's more about integrating it as soon as possible. And there are ways of doing it. I mean, the meaning of making or meaning. Reconstruction is about how you create a narrative, how you organize that, your personal experiences into a story that connect everything, like the past, the present, and the future. Identifying the reconstruction part, so it's understanding how the loss reshapes one's self concept, right? I mean, how losing your family member define yourself, and how not having that family member, that shattered identity of yourself now, how you fill the gaps that are, for not having that person. Sometimes we don't know. I mean, what gaps or what that person purpose was in our life until we lose it, right? You don't know what you have until you lose it. I mean, that, no sabes lo que tiene hasta que lo pierdes. So that's part of the process, right? Reconstructing what you don't have. And there's a purpose renewal. It's finding new ways of engaging with the life and honor the disease. So it's again, that integrated grief. The cognitive stress theory. So there's some concept about it. It's just a recovery after the loss. But there's a lot of stress appraisal. So it's how we interpreted the loss and how that loss affect us emotionally. Also, how we cope with that loss. I mean, with active coping. I mean, it could be problem solving, reframing versus the avoidance that we talk about. There's a lot of positive emotion activation, distress minimization. Also, the application in grief, right? Encouraging grief and intentionally breaking from the grief-related distress that foster recovery. So if you're having things that remind you to that person, or you're going places that remind you to that person, so maybe for now until you decrease that stress level, it's better a good idea not to go through those triggers, okay? Because that would trigger a lot of emotional distress that you're not ready for. So thinking about positive memories, meaningful activities can coexist with the sadness of loss. And we talk about that. One of my patients, like to go to the cemetery with a cake every year. So she's sad, but at the same time, she's adding some joy to the event and coexist the emotional sadness of not having someone versus the joy that was having them in the past. In terms of Latinos and Hispanic, we use a lot of music. Um, we some people meet in some kind of dinner, and they invite people outside, the neighbors. Uh, there's a lot of religious ceremonies. I mean, the people that celebrate the 10 years, the 5 years, the 50 years of someone uh, uh, dying, right, as a memory, and they invite all the community, humor as a tool or emotional regulation. Uh, so, so that's part of it. There's a dual process model which combine all these that we talk about, the oriented coping, which is restoration oriented coping. And it's just about the same. It's just about, kind of managing and the rebuilding of yourself, of what that person used to be, and what you're going to do after they're not here. In Hispanics, in terms of cultural components to this, again, is if not losing those memorial masses. So in terms of I cannot go there, so trying to go to the masses about this person, doing a collective morning ritual to that person, so be part of that community and grieve with your family members at the same time. Doing caregiving to other, kind of displacing that sadness in ways, helping others, and resuming cultural celebration again. So that trying to rebuild, be part of it instead of the hiding and avoiding situation. There's something called we oscillate between the processes. So, but still, when you oscillate between the loss-oriented stress versus the restoration-oriented process, it could be overwhelming. But at the same time, it gives you some skill when you jump around versus just staying in one. You can have both. I mean, loss-oriented and restoration-oriented. You can have those in different family members. So for someone that is trying to heal as a family, it's better to incorporate them and try different skills and different ways of integrating everyone of the family, to prevent emotional overwhelming, and not only be constantly thinking or focused on the loss, but also on the moving forward and supporting functional recovery for every member. I mean, every human feels grief in a different way, so that's important to keep in mind. I think this is the kind of the favorite stages of grief that we use in our culture. The denial, the anger, the bargaining, the depression, the acceptance. I think that's the 5 stages. There are a lot of stages out there. There's a lot of theories. I mean, this is one of them, the Kubler-Ross. And I think that's the one I use the most to. I'm probably you guys have heard the most of in terms of stages of grief. And there is no, I would say there's no order to it. I mean, you can be on any of the stage at any time. I mean, some people react, probably the basic emotion would be anger, but you will be surprised. There are some people that accept pretty quick, and they probably never feel anger. Even, maybe a little bit, but the acceptance come pretty quick for those people. And there's some people that stay a long time in every single one of this. And of course, it doesn't mean that it's a disorder. It's just you're just stages, right? We're not at this point. We're not diagnosing someone with this. It's someone just going through grief, grieving the loss. Another theory is the stage of grief from Maciejewski. I might be pronouncing that wrong, but and is pretty similar, but they call it different different ways. So disbelief, the yearning, the anger, depression, and acceptance, right? Just, pretty similar, just different emotions. There are others that define stages in seven stages. I mean, there's one that it's just a shock and the denial, the pain and guilt, the anger and bargaining. But again, similar emotions. There's always the anger, there's always the depression, there's always the acceptance. Some people call it the reconstruction phase or the working through phase instead of the acceptance, and or the upward turn. So it's the point that the stage of grief, like anger and pain, have died down, and you have left with the calm and the relaxed state and then you move to acceptance. Um, Higher risk of following disorder during acute bereavement. So there's a higher risk of comorbidities, and especially with those people that have already uh, dealt with these disorders in the past. So major depressive disorder and anxiety are the big ones. Uh, and there's the prolonged grief disorder, which is the intense preoccupation and difficulty accepting the death beyond, the cultural expected time frames. And when they say culturally expected time frame, I mean every community, every I guess country or even families have their time frame of how much you're gonna grieve for this person. Um, PTSD, I mean, yes, it could happen, especially if the death is sudden and violent. I mean, we see that a lot in Hispanic communities, especially in big cities. I mean, Puerto Rico, I consider Puerto Rico like a country, a place that do suffer a lot from the traumatic experiences from violence and losing their kids and violence in places that they trust, right? Like church, schools, and things like that. And big cities. I mean, Philadelphia most of my patients have some traumatic stress disorder component to their disorders. And substance use, of course, I mean, there's a way of coping, and some people cope with substances, and this can create a disorder. It come from just drinking the day of the passing, but the forgetting, the rumination keeps yourself drinking and converting to a disorder. Suicide ideation and behaviors are not that uncommon, so they're pretty common. I mean, people say, I would like to go with that person, or why now? Why not me? I mean, and those are pretty common human feelings that people have. I mean, and there's elevated short-term risk. Yes, be worried, but it's not a massive risk unless it's compared to a prolonged grief disorder and the patient, the person, sorry, I keep saying patient, the person keep mentioning and having uh, these thoughts, right? Especially when there's a spouse, as I put there. I mean, the examples are spouse and child. Those are really big losses, right? When you lose a kid, no one wants to bury a child, and your spouse, which is probably your best friend or the person that give you the structure. Um, so especially if there's a dependency on that relationship. The persistent complex bereavement, which is a DSM-5 disorder, is just that persistent, right? It's longing for the disease, I mean, intense sorrow and emotional pain respond to death. Uh, it doesn't mean that it could be death in general. I mean, so for these patients, you like watching TV, watching the news should be a no-no. Because anything related to death or violence or the act of killing, right, or someone dying, like sickness, is a no. I mean, it trigger this preoccupation or rumination with the disease. A lot of patients during COVID-19 suffer from this complex bereavement. I mean, it was a pretty shocking moment. No one understood what was going on. So patients with this type of vulnerabilities were higher risk. So it's just the preoccupation of the circumstances of the death. I mean, always the what if, what happened, why them, and not me. There's a reactive distress to the death. in this persistent complex bereavement and experiences disbelief, emotional numbness over the loss. There's a lot of denial, acceptance never happened, a lot of anger related to the loss. So it's pretty reactive, maladaptive, and it's the self-blame, right? That self-blame is really important to treat in therapy. Usually it takes a route of avoidance of reminders of the loss, so they prefer not to go outside or spend time with the family, so that creates a loneliness, and of course create major depressive disorders, anxiety, social phobias, things like that. So they don't go to places, they stop working, they don't want to be in a situation where kids are around or people look happy because they're dating or have a relationship. They want that you lost. So it's a lot of that. There's a social identity disruption in these cases, a desire to die in order to be with the disease, not of killing themselves, right? It's just I cannot wait to die, right? So usually patients like this, they start not taking their diabetes medication or taking the hypertensive, just letting themselves die. Intentional or maybe unconscious a way of killing yourself slowly. And of course, the loneliness increased, and they start detaching from others. I'm feeling the life is meaningless. A good example. I have a patient that a mom died, and of course the daughters stay alive. One of them suffered from persistent complex bereavement, so she detached from her sisters, right, when mother died. So, and that's not uncommon, especially for Hispanic communities, when the head of the family, we'll call it that way, like a grandmother or a mother or father pass away. Is just the structure of the family trouble, and some people suffer from these complex bereavement disorders, which are the most cases challenging when you have a sister detaching from the family because not accepting the death of the head of the family. So a lot of confusion on the role in life, right? What do I do now? It happens a lot when the spouse pass away. There's pretty sure you guys heard that have experience with someone, when you have a couple that have been together for a while and then one died and the other one probably died months later or years later, pretty close to the death of the spouse or the partner. So they call it the heart broken syndrome. So it happens. It happened. A sense of one identity is gone. So it's like feeling that part of oneself, died with the disease. So what's the point of keep going? So that's all part of the persistent complex bereavement disorder. We don't use that diagnosis often, but I think it's there, and we don't use it as we should. We're always looking for the PTSD or the traumatics, but it could be just related to the disease, right? To the loss of that person or one person. There's some data about the prevalence of complicated grief. Rates can rise to 20-30% in cases of a child versus spouse. Of course, when they're violent and sudden and traumatic death. I have a patient that son was killed because he was protecting the neighbor. So in a case like that, mom saw when the son was shot, and she never understood. He was a good boy. So he died because he was saving someone else. He doesn't deserve to die. So she's dealing with this complicated grief for the past 5 years because he was really a good boy. He was a good son, and he only died because he tried to save the neighbor. So a lot of self-blame. He was there visiting me, or he was there late because I asked him to drive home because I was feeling I needed to see him. So she deals with this denial and guilt that is not, it's not helping. I mean, it's just getting sick and sicker. Um, so so relationships that are close to you put you at higher risk of that, especially if you have a low social support, right? That was my only son situation. That's pretty rough. Yeah, it's pretty it's pretty risky for someone like that to lose that significant other. Um, Among the psychiatric outpatient with major depressive disorder or PTSD, about 30 to 50%, so half of them, may meet criteria for the prolonged grief disorder. Prevalence can vary across cultures. I think the Hispanic Latino communities, because of the strong family bond and the culture of the practices, they have a little bit more support in terms I mean, like a buffer against these disorders because they have more support when you compare to other culture. But of course, I mean, there's some things that prolong intense grief depending on the person and die and how they died and things like that. Um, Also, it's associated with sleep disturbances, of course, nightmares, bad dreams that can be linked to a post-traumatic stress disorder, but not always. It can be an insomnia that is, separated from a disorder itself. The suicide thinking and behaviors, but no actions or plans. It's just that feeling of I want to die, or thinking about passive death wishes. Impairment in other relationships. I mean, it happens a lot with spouses and partners. You know, I don't want to date. I have not dated 10 years. It's my wife, husband, partner died. Because that's not fair for that person, right? Or I don't feel ready. Um, so that's pretty common. Then, of course, the substance use and addiction psychiatrists, I see a lot of substance use disorders, especially alcohol is pretty common in our communities. A risk factor for suicide during the bereavement. So, and it's, of course, most common when you lose a child or your partner. Uh, so is I mean, the things to look for is the nature of the death, the relationship to that person, and if there's comorbidities, right? I think those factors are pretty important. Also, and I'm pretty sure you guys know how to do an HPI or history of present illness and look for the risk factors, someone suicide, or if not, I mean, use a scale, the Columbia scale, or whatever you guys use in your practices. But I mean, these risks are really important. So the relationship, which is, you know, who died and how they died. Also, the psychiatric and psychological factors the patient have at that moment. Also, the social environment factors. I mean, the social isolation, the stigma. Does the patient or that person die from suicide versus an overdose versus from HIV, AIDS, or any related disorders, or he was shot because he was, you know, he was in the wrong pathways. So all that has to be there. It has to be part of the diagnosis, of the assessment, and the treatment plan for that person. There's complicated and prolonged grief disorders. I mean, this which are persistent, and it's the inability of imagine life without that person. So that's really important. Also, look for the shame, the identification with that disease person. I should be there with them. I mean, that's like everything's lost without them. Um, in terms of Hispanic Latino context, I mean, strong family, as I said, is a buffer. And we have been, there's a lot of data um, of that. And of course, that's a protective factor for a lot of stuff, or for depression, for anxiety, for suicide, but also for this prolonged grief or risk factor for bereavement. Um, And I mean, some of my patient has to move out from the area or the community, and just that also is a loss. And I lost my son. Everything reminds me to my son, so I need to move from all the triggers are around. Which sometimes that means that they need to get out of the community that they grew up, or the neighbors that were supported to her or him. So that could be another loss, right? So moving because I lost someone to a place that I don't know and losing all that connection is a big loss. So we need to work with that transition, even if it's the best for that person. Um, Once we have some improvement, I mean, the maintenance of the complicated grief is there, similarly to when we work with someone with substance disorder, the relapsing component, the recovery management is really important. So because it's a persistent maladaptive thoughts, right? I mean, those thoughts are ruminating around your head. They're always going to be there when you have this complicated grief. So we need to identify the avoidance behaviors. And, and we talk a little bit about that, the loss-oriented versus the restoration-oriented avoidance. Also, avoid the disrupted attachment system. So when we have attachment that are not good attachments, and this could be attachment to anything, material things, uh, drugs. I have patients that suffer from behavior addictions like gambling, sex, and things like that. So we need to eliminate those from the rebuilding, the restoration period. So difficulties integrating the loss into the self narrative, the new you, should be without this attachment systems, right? No gambling if you can, no drugs if you can, no prostitution if you can. So stay away from those settings. And of course, as always, keep an eye on those current disorders, the depression, the PTSD, the substance use. I mean, we need to treat both. I mean, if we're treating the grief, we need to be careful with, not treating a major depressive disorder or PTSD that is underlying or even in the surface in front of you. So, of course, we need to keep asking questions outside just that complicated grief. Social and cultural factors, isolation and lack of supportive social networks at risk. There's some cultural norms that discourage emotional expression, especially males. I mean, we still in our Latino, Hispanic context, we have the machismo, which is pretty rampant these days, and not, I'm strong, I'm a male, I'm the head of the family, so I should not feel this way. My wife died, but I need to keep moving. My son died, but I need to show my wife that I'm okay. So that kind of situation, while our very culturally strong, I mean, we need to work with that and offer support. And always, I mean, if you cannot deal with that in the family, it's always good to go to therapy or accept medications. But of course, I mean, you have the machismo, and the machismo there is really hard to accept help. And without that integration in the lifestyle or your feelings, it just reports in that ongoing preoccupation with the loss. So you are not healing, you're just avoiding. So more about the complicated grief is all maintained by interaction of that maladaptive beliefs, the avoidance, the emotional dysregulation, and the social and cultural reinforcement. Of course, if you use them. So, uh, so I mentioned COVID-19. This is a study back in 2024. So how COVID-19 really affect these transitional settings and disrupted the bereavement and on some families, especially Latino. So we saw a lot of the disrupted practices because people was not, churches were not available, the rituals were not done. It was hard to travel, see family. So that created a lot of related trauma and stress, especially with relocation and moving away from the area. Of course, during COVID-19, you were moving, but you were moving to a place that you didn't know people. Plus, you were not able to get outside, right? It was not allowed to travel or going outside to meet your neighbors and anything. So this factor created significant barriers to grief adaptation. So those people that lost a lot of people they used to know during that time still dealing with this grief, but were unable to process that grief. Um, Also, when we talk about the grief and bereavement of Latinos community, I mean, there's a lot of findings. This is from 2022 that individuals often display grief intensity and psychological responses compared to white counterparts. So it's pretty similar, but what affects them the most is the disruption of these cultural rituals and the cultural differences, right? So if we disrupt those, the risk of having unresolved complicated grief increase. That makes sense, right? I mean, they're related, right? Both studies. So of course, COVID-19 it was a disruption of the cultural traditions, right? The structure that Latinos and Hispanic community have, but also not having that for X, Y reason, because you're isolating or you have it's an intense grief and you prefer the attachment disruption route, it will create long-term complicated grief. It does not treat it. Traumatic grief and PTSD, I mean, there's some similarities. Sorry. So both can be triggered by sudden and violent unexpected death of a loved one or someone you know. Overlapping symptoms are, I mean, you can probably guess what they are. I mean, the thoughts, the images, the memories, the avoidance, the hyperarousal, so that irritability, the difficulty sleeping, the blame, the emotional numbness, which is reduced capacity for positive emotions. So you feel heavy, you don't care about anything. You're like your affect is blunted, flat. Nothing really do. Nothing is enough. And that emotion, I mean, the themes around that emotion is the persistent guilt, the self-blame, or a sense of injustice, right? The patient I told you about, son was killed in front of her door because he was saving a neighbor that probably was not even close to the family. So that persistent guilt, I mean, he was there because I would call him to be there. So worry about the circumstances of the death. In this case, well, she's worried about catching the man that fired the gun or shot my son. So that's still disruption, guilt, screaming why the police is not doing their job. So that has been like 5 years of that. So this is a pretty good example of complicated grief. Feeling unsafe and unpredictable is one of them. And I mean, in the case of my patient, she still lived there, right? She still lived close to the place that her son was shot. So insecure attachment styles, and this is really important. I mean, those of you guys that have kids, we need to work in attachment theories a little bit and what we offer the child. I mean, this is a different topic, but probably different presentation, but it's related, right? Because the way we act and grief has a lot to do with the way we were raised and the theories of the person that we model or we were watching or seeing and we learn from. So some core features. So fear of abandonment is a big one. We see that a lot of the personality disorders. We see that a lot in depression. We see that a lot on substance use disorders. I mean, this is the fear of abandonment, right? The fear of being abandoned. The hypervigilance and to relationship, to threat, the I love you, I hate your situation, the dependency on close others or for validation, right? So someone that tells you you're beautiful, someone that tells you you're enough. We didn't have enough of that when we were growing up. So now we search for it, we look for it. So that can create attachment styles. So in grief, we see it presenting as difficulty accepting the reality of the loss, the prolonged searching and ruminating for answers, the higher risk of complicated grief because of attachment, and it's just at any moment, any time that can happen to you. So you still have going to that attachment the attachment style you were raised with. Insecure attachment style, we talk about this, is avoidant, dismissive attachment. And this is super simplified for this presentation. I mean, there are a lot more styles, but just mentioning a few here, so you guys start asking yourself when you see a patient, or even when you think about yourself, right? I mean, what style I am? What am I? So core features, preference for emotional distance, discomfort with dependency, suppression of attachment needs. So in grief, we see this type of style. They might minimize and downplay the loss. Everything okay, I don't want to talk about it. I just want to go to work. So avoid the emotion. So this is just suppressing or repressing, right? Because suppressing is unconscious versus repressing is conscious. So depending on psychodynamic situation here, but so you are just repressing the situations here. So you're not talking about it, so it's avoided. There's a disorganized feel for avoidant attachment. Which core features are a combination of this and anxiety and avoidance patterns. So the loss can trigger extreme emotions dysregulation, also a strong predictor of traumatic grief and PTSD. In terms of DSM-5, I'm not going to go over this that much, but just for you guys to see some of the similarities of complex grief versus PTSD, post-traumatic stress disorder. So it can happen. I mean, I think these slides will be enough, but it can happen directly, when you experience the loss or the traumatic event. It can happen because you witness a big loss of someone else. So that example I give you of the third distant uncle that passed away from cancer, I never met him, but doctor, I feel super sad about his death. And I don't know what to do. I don't know. Never met the guy, but I do feel sad. I feel sad. It's a big loss for the family. So that grief period, that grieving process is real. It's real, even for someone that my patient never met. Also experiencing, and this is different DSM-5 versus different DSM-4, but this last one is experiencing repeated or extreme exposure to aversive details, right? So people that lose patients every day. ER doctors, I don't know, surgeons might happen that, or if you work I used to work in a rehab, that people die from overdoses pretty often. It was a pretty high risk population. So you see that repetitive, policemen, firemen, people dying in front of you, those losses, seeing people cry and the family, explaining to the family member that you lost your patient, which is their family member. That is a lot of emotions, and it can happen. It's a collective repeated experience for this for these people. So that can create some grief and loss sense. This is just PTSD, so I'm going to move forward. But of course, it's pretty similar to the criterion 8 of a complex bereavement disorder. It's just the perception of death. It has a lot to do with this, especially the why and the how they die. So that, I don't think we do try to be prepared, or try to be, have a good perception of how death look like and how to prepare for it. But when it happens, you are not really ever prepared. So there's some instruments that we can use in terms of diagnosing or treating or identifying the symptoms. The inventory of complicated grief is a good one. It's been around for a while. So the purpose is just measuring maladaptive symptoms of grief. There is one that's a little bit prolonged, the grief scale. So just a few more questions, but it does align with the ICD-11. So it's been fixed from 95 to 29. is available on other languages, including Spanish. So that's good. There's a Texas inventory of grief. Again, this one measures past and current grief intensity. And of course, I mean, past action, past emotions has a lot to do with your present. However, grief can be different depending on the people that died and also the way they died. So it depends, but those are options as well. The grief experience questionnaire, the same, but this one add a little bit on the guilt, somatic reaction, which are pretty common in Hispanic communities. The bereavement and the phenomenology questionnaire is just focused on the subjective experiences, including the spiritual and existential dimensions. So this one is a little bit more for people that are believers of the spiritual part of you. And of course, I think it's really important to add to those scales of bereavement, also, some scales about depression, even if the PHQ-9 and the PTSD checklist, the PCL 5. I think those are really important to include when you're doing assessment for someone dealing with complicated grief. In terms of treatment, there's not a magic bullet, a magic way of treating this. There is some great therapy. The complicated grief therapy is available. It's evidence-based, it's manualized. So there's a therapy, there's a manual you can use. There's exposure-based techniques. So it's focusing on the work of losing that person and revisiting memories. I do a lot of CBT and prolonged exposure therapy. Prolonged exposure therapy, it's just I do it sometimes, but CBT is great. It's pretty available, and you can tweak it here and there to treat specific symptoms and maladaptive behaviors. So there's a CBT specific for grief, that was published back in 2006. But there's a CBT for everything, any behavior out there, suicide, insomnia, so any symptoms that are part of that process, you can do CBT for, especially those that affect the patient the most. Group and family intervention, that really depend. I cannot speak too much about family interventions. I don't do them, but I do sometimes partners and relationship like that, but no family intervention from more than two people. But they help. I mean, especially on Hispanic communities, the adaptation to the family, especially if you lose the head of the family. And of course, we should do it in Spanish if there are Spanish speakers, and includes that cultural component to it. Self-care and cultural rituals, we still, that's part of a tradition. Just keep going, keep doing it. Don't take the avoidance route. I mean, include them on that reconstruction that we talk about. So it's pretty, I encourage it, especially if your family believes in it. Even if you don't believe in them, be part of that process with the family. It's really important. So some examples: memorial masses, storytelling, music, cooking tradition dishes. In Puerto Rico has, I don't know, different states, but Puerto Rico, they have different rituals that are pretty interesting and impressive. And of course, people keep doing them. I'm not going to talk much about that, but if you're from Puerto Rico, you know probably what I'm talking about, which is, before the body is buried, they create a scenario, in the favorite bands or probably, I don't know, hobbies that the patient have, like, they put the body riding a motorcycle, they put the body doing some kind of activity that they used to like, and they celebrate that event with the family. Of course, and also we need to include that holistic part of treatment, which is promoting the physical health, sleep, and nutrition activities. There's a case, Maria. I mentioned a few cases here, but this is I think is a good case. Grief and mental health in a Hispanic context. So Maria is Puerto Rican. We live in Philadelphia for the last 15 years. So she was in the 30s when she moved here. Married, works part-time at a community center. She's bilingual. She see me because she lost her son in a car accident. 21 years old. And she's presenting 10 months after, which in theory, that's already a little bit complicated grief here, which usually not complicated, but it could be chronic if it lasts more than 6 months at times. But it could be bad or good, right? Grief is not always bad. It depends what kind of symptoms it's causing. In her case, she's unable to accept the loss, right? So it's disruptive already. She cannot sleep. She doesn't have an appetite. She's losing weight. So we already have some symptom signs of something else going on. Could be a major depressive disorder, maybe PTSD. But let's keep reading. She presents with disattachment styles, which I always mention on my notes. I look for that. And some patients, especially when they lose someone, when going through a loss, which is the anxiety or preoccupied with a strong dependency on son. In her case, son was the first one. It was her favorite, in her words. And they had a pretty strong bond, right? And she's from a Catholic faith. And of course, COVID-19 was disrupted, and there's a lot of restrictions. So some risk factors on this is the sudden traumatic death. He died in an accident, so that's pretty traumatic itself. So losing the child is already traumatic, especially if it's your favorite, you're closer to him. He was your protective being. He was the one that always protect you, that you were waiting for him to take care of you when you get older. So things like that always plays in the head. So she's isolating. So we can use a few of the assessment that we talk about. In her case, we include the PHQ-9, but there is the prolonged grief disorder because it's been in 10 months already. She's having some symptoms. Very probably complicated because of the time and the symptoms of insomnia, losing weight, which is physical symptoms as well. She it sounds like a moderate depression, more than 2 weeks, some symptoms, sadness, and I didn't touch all the criteria, but we're thinking about it. That's what we do in the instruments. I'm not diagnosing her yet. And maybe some PTSD symptoms. So how you formulate a case like this? So in terms of diagnosis and formulation, so of course there's a loss. So we need to have that prolonged grief disorder because 10 months and the loss, and need to rule out PTSD and major depressive disorder. So those are in the differential diagnosis. We're just meeting the patient, so we don't know much about her past, but in terms of present, this is how she's presenting. In terms of formulation, we're talking about attachment theory. In her case, she's dependent on her son. She's pretty anxious, so it's similar. It's like a mix of anxiety style versus attachment, difficulty accepting separation. There is a dual process model in terms of how she feels stuck in the loss-oriented coping of losing her son. In terms of the meaning of the loss for her, she has not integrated the loss into her life yet. So that's a big risk factor there. There's a minimal positive emotional activation from the loss. So there's no joy, there's no relief yet. And that comes with the no accepting the death. And of course, we're not even talking about maintenance yet, because there is a lot of factors that prevent that: the rumination, avoidance, and isolation, and the disrupted ritual. She doesn't want to participate in anything. How we treat this, it's a big question. So need to include a lot of things. Probably therapy, and also creating a support system for this patient. In terms of therapy, medication, I don't want to talk much about medication, but pretty basic stuff. If we're thinking about PTSD and depression, I would go SSRIs, the serotonin, reuptake inhibitors first. I think there are a lot of data behind them. But if we don't decide medication, there's a lot of or coaching and therapy we can do, especially promoting and encouraging this adaptation of rituals and and the reconstruction we talk about. CBT doesn't have to be manualized, but at least CBT skills to teach, talk about complicated grief theory and therapy, and of course normalize some of her symptoms. Not all of them, but some of her symptoms, right? So the grief response is normal. The way he died is not normal. So we need to try to maybe not normalize the situation, but feel for her and offer the support. So I don't know if we have time, but there's a few questions. I mean, so how we identify risk factors? Anything in this case? How do cultural practice protect or prolong grief in this case? We talk a little bit about the tools, but how do we differentiate the prolonged grief disorder versus a PTSD? I mean, we talk a little bit about that, and how to adapt intervention in Hispanic Latino clients with limited access. I mean, we mentioned a few supportive ways of doing that. We had about 10 minutes, I think. So I would like to have questions. Maybe I see that the chat has been pretty busy. So what should we do?
All right. So
There's a lot of questions, but I don't know which ones are first or not.
yeah, so I don't know if you can see the chat. Can you?
I can see it, but I don't know. I mean, I can go back and see the
Yeah,
times.
no, you can go to the very bottom, and
Okay.
there's a very long one from Kira Arano.
If you want to unmute yourself and just ask, I mean, that would be good
Yeah,
too.
you can all raise your hands and I can unmute you.
Yeah.
There it is. Okay.
Okay. Yeah, thanks. I was asking about using prolonged grief disorder as a diagnosis when there is migratory grief or prolonged grief. I think is grief what comes from after immigration, mourning your country and your culture, your status, extreme loneliness, difficulty integrating, that like grief is normal and isn't necessarily a pathology, but can go on for years and years. And maybe people need some help to feel better, right? To live their life.
Yeah.
But it doesn't fit, like adjustment disorders are like too short a time. It's like 6 months time. And it doesn't fit PTSD necessarily. So I wonder if since migratory grief or Ulysses syndrome are not in the DSM,
Right.
if you think prolonged grief may fit that situation.
Oh, it depends on the symptoms, right? I mean, it could be normal grief. And I don't know, there's a DSM, probably not a DSM-5, but probably an ICD code for that. So it depends on the symptoms. I mean, yes, we can all have grief, especially if we are migrating or refugees or why not? I mean, even my I can speak about myself. I mean, I have a lot of grief from living in Puerto Rico, living here in Philadelphia. But the funny part about that, there's always a way of treating your grief. The way I treat it is by treating Hispanics and going to Hispanic galas and supporting the community in different ways, right? So I work for something called Asociación Puertorriqueños en Marcha. So I work with Puerto Ricans. So that's the way I'm grieving, right? But in terms of migration, it could be multi-generational grief as well, which is pretty complex. I would call it complex on that situation because not only you know, as a head, at the first that move, but also what comes after you, who comes after you, it might be getting that grief from you as well. Because you want to go back. That's always the plan when we migrate, right? And we always, unless something happened, but we always thinking about what, you know, if we don't forget about our roots and where we came from. I mean, that's always in our head. So I would look for something that, and I don't have the DSM-5 here, but it could be the grieving process. It doesn't have to be complicated bereavement, but it could be prolonged. It could be prolonged, and it could be in remission or active with depression, with anxiety. So you can create that a last name for that diagnosis, but look for that diagnosis as it could be prolonged, but maybe not as complicated. Adjustment disorder depends when she's presenting or he's presenting and how long it has been. I mean, there is also prolonged or complex adjustment with mixed features and things like that. So, but it's a pretty broad event, but it could be an adjustment disorder as well. Depends how long you're going to have the patient for, what are you treating for, and the symptoms she's presenting or he's presenting with.
Thank you.
Yeah.
Okay, so we have another hand raised.
Can you hear me now?
Yes.
Yeah, thank you. Yeah, so thank you, Mr. Hector Colon, for this presentation, for bringing up what, sometimes is forgotten or omitted. And I have a question for the Dia de los Muertos, because I'm Mexican and I have, I know that and I love that celebration, and I have, made a lot of studies as a psychologist. You were talking about the Day of the Dead as something that I couldn't catch, but
yeah. No, I mentioned that it's just an example of how some Hispanic communities deal with the loss of someone, right? I mean, celebrating the memory, celebrating that event. But it's a way of dealing with that topic of the death, right? That's not just the end; it continues.
So then it's not a pathology.
No. I'm just no. I mean, it's a way of how. No, I would never say that's a pathology.
Integrated grief, right?
Right. It's how they continue, and it's just an example of how some countries, like Hispanic countries, deal with death in general, and it's just they express the continuation of it's like a continuation of life. It's not just finished there, right? And those memories they integrate to their lifestyle and their living. And we saw that in the movie, right? How they're together again, right?
Okay, so then you are saying that it's a tradition and it's a culture, and also because
also a coping skill. Yeah, it's a pretty good
exactly.
Yeah,
it's a skill because it's not just it's a tradition, but the Mexicans, as other cultures, they have rituals so we can process. Like the ritual to go, for example, the quinceañera is another stage, like the sweet 16. So they are it's a way to process, a ritual to a passage process. So thank you for mentioning. And the Coco movie has a lot of cliches. So it's a first introduction reference, but not everybody has the same rituals.
right.
And also the Day of the Dead is already how do you say, like a mestizo product, because we used to honor. We used to honor 2 Aztec months. The Aztec months was 20 days. So for 40 days, we were honoring the people that passed away. So then when the Spaniards conquered us and kill us, massacre us, etc., they said you are allowed 2 days that is going to match with the harvest, Right. So then this is the result of what we could do. But we had another kind of life, honor the people that is dead for life, not just 2 days in a Coco movie, no? Disney.
No, yeah.
Coco nice, no? So but thank you for mentioning, and Coco is a good introduction, but it's not exactly what it is.
Right. No, thank you for that. Thank you for that.
No, thank you, Mr. Hector. Bye.
Yeah.
So we have a question in the chat that says, if there is a death by suicide, how do you discuss the possibility of SI with family members who are grieving?
Yeah, that's a tough one. It depends on the family belief on suicide versus what kind of religion they have and this is accepted or not. So I have dealt with that before, even in my family. So there was a death by suicide in my family. There are Buddhists, and they were not accepting that this was a suicide. So it took time. It took time to process that. I would not introduce that thought too fast. I would just let the natural process of grieving happen. And I would say when the family is ready, especially the mom and dad, I would deal with the death. You just the emotion, the big loss, right? I don't think the why in that moment is really that important, right? If you're dealing with emotions first. So I would treat the emotions, I would treat the way they're presented. I mean, just meet the patient where they are uh, before kind of focusing on on that particular the why, right? The why the death is still a big loss for the family. It doesn't matter if it was suicide, overdose, kill, violent or not violent, an accident. I feel still a process of grieving, and it's a process where you meet the patient where they are, and with time we can talk a little bit about the acceptance and the why this happened, even though if there's a guilt about to kill himself or he kill himself, but there's no a guilt process about that, and they want to protect the family. I mean, there's also the social situation, right? They want to protect the family from suicide. It looks bad, mental illness, da. But for that patient that's coming to you, I think meeting where they are and just treating what you're seeing and helping them to process the grief is important. Not really the why, unless they bring it up, right?
All right, so I guess we have time for one or two. Do we have current research on the Hispanic community and the separation of family members due to the deportations and how their mental health is being impacted?
Well, we're not allowed to talk about politics, but I think there's ongoing research. I kind of participated in a lot with the American Psychiatry Association, and there's a lot of talks about how we can create positional statements and for these situations. But yeah, we talk about acute grief versus chronic grief and the acute shock, right, of seeing your partner, your family member being separated from the family and sent to a country that they've never been before, and that process, the legal process, the expenses, all of that is trauma. It's not only just a grief process; it's just events that happen really fast that's hard to process, right? When someone is taken like that, I mean, you're still dealing with other stressors before you even had the time to process your grief. So I would say, again, it's similar to what I said before about the suicide. If the patient is presenting with that, just meet where they are at and kind of the trigger, if it's the taken, if it's the legal, if it's the unknown, I don't know when I'm going to see them, or it's because they send it to, I don't know, another country, the Congo, whatever. Just process that with them. It's a long process in terms of deportation and things like that. But yeah, I mean, meet them when they are where they are. In terms of how we can help that, I mean, I think we need to be probably advocate. Don't want to create. I'm always in between activist and advocate. I think advocating for a due process is really important.
Okay, we have Kenya Marquez also raising their hand again, so you may unmute yourself.
Thank you. Yeah, I have like a question. I remember when I came to this country, it was 22 years ago, and they gave me, I was working with an agency and we were working with insurances, medical insurance. So they told us, you have 5 sessions to cure depression. But that it was grieving, because, for example, the mom died, they couldn't go back to to bury her and to mourn her. So then it was It was guilty, it was sadness, it was a lot of things complicated. So when they give me 5 sessions, I was trying to explain to Hispanic supervisors that we may not like heal someone in 5 sessions, like a morning, a grieving, regular grieving from here from the United States that lost someone. That it was still few. And they just told me, well, that is the system, that is what they pay. So just comment that is horrible because morning, the mom that died and you came to work for your mom and send money and now you cannot even go back to bury her. It's horrible. So the balance between the reality, different realities, no, and treatment, like what we allowed to do. What do you think, Mr. Hector?
Well, we're talking about the systemic,
Uh-huh.
I guess, barriers to treat someone, but I mean, it depends on the system you work and where you are and the resources of that community. There's a lot of programs that do longer therapies, but yes, they limit us depending on the grants or whatever resources you have. I don't think there is a number for anyone to process. I mean, this is really patient centered. It's individual treatment plans. I mean, any human out there would, I guess, process grief in a different way. So you cannot tell a mom you have 5 hours to move on. You cannot say a dad you have 1 hour. I mean, it's just some people need 20 minutes. Some people need a life. So I don't think putting a number is fair to anyone. So, but the system likes numbers, they like structure, and most of the time doesn't work.
Okay,
Well,
Dr. Colon, we have one last question, and if you could please put the evaluation slide. It is also being shared through the chat, and so I'm gonna allow Jose Reyes.
There's a good resource I work for. It's called the RMTAC, which is Refugees Migrant Technical Support, and it's free. You can go to the website. It's RMTAC. It's a SAMHSA grant and it's completely free. So they have a lot of resources you can ask for. If you have a clinic, we can go to you. We can send someone to talk to you about the particular cases you're dealing with or situation you're dealing with. So, thank you for putting there, Esther. So that's our link. But also, the APA have a new website. It's lasaludmental.org, lasaludmental.org, which we have a lot of resources in Spanish and Q&As and things like that, and social media. So please look at it. It's lasaludmental.org. It's pretty good, and we talk about a lot of this as well.
Yes, thank you, Doctor. Can you please share the slide with the evaluation? Is at the
sorry.
end.
Sorry, my bad. Got distracted. Sorry. There you go.
And Jose Reyes, you may unmute to ask your question. All right, so I guess they are not there anymore. The link is being shared through the chat. It is very important, your opinion. There you'll be able to let us know if you enjoy the presentation and if there are other topics that you would like for us to develop or to continue providing. The presentation, again, for everybody, it's going to be posted also in our webpage. It's been shared through the chat a few times, but you'll be able to find it today with the same name of today's presentation. There is a comment, Dr. Colon, that says, there are many. They're continuing to go. I just lost so many of them.
So, I don't know if I cannot type on the chat, but if you can put the RMTAC, I think Esther put it there, but that's alumni.org as well.
Let me see. Also, the participant presentation, the participant certification is gonna be being sent a week from now. So then again, please fill out the evaluation form. If you have any doubts or question, you can feel free to reach out. And the recording of today's webinar should be posted also in our YouTube and our webpage. If there are no more questions, Dr. Colon, we have a lot of thank you comments.
Yes.
And thank you so much for being here today. So we're gonna go and let you guys go. Thank you so much, Dr. Colon, again for today.